Hello. I'm going to go ahead and record a version of infectious respiratory problems so that you've got the complete set, the in-place live version and the one that you can just play over and over again. So with upper airway infections, my main purpose in discussing these is to familiarize you with the terminology and give you an idea about them, because oftentimes these upper airway problems can lead to more significant lower airway problems or other infectious processes. So rhinitis is inflammation of the nares, usually that is with running nose. That can be from an infectious or allergic source. The infectious sources are either viral or bacterial. The predominant amount of rhinitis or upper respiratory infections are going to be viral in nature. And then allergic rhinitis typically is something that people are able to recognize based on maybe what happens seasonally. So in the fall and the spring, they start having symptoms that go along with allergies. So runny nose, maybe itchy eyes, that type of thing. Sinusitis, now looking at inflammation within the sinus cavities. This is something that typically will be because of a viral or bacterial etiology. And one of the main factors that is helpful in discriminating between what is viral and what is bacterial oftentimes is looking at the duration of illness. So that problems that are viral, usually that's sort of the beginning of whatever the problem may be. Most viral upper respiratory infections begin and go on for about 7 to 10 days. So once the illness exceeds that time, there's an increased likelihood that it might have gone on to develop a secondary bacterial infection on top of the virus. And a lot of times what you'll see is that the person will have had the URI, have a sense of being sick, and then around day 7 or 10 will start to feel better. And they'll think they're on the road to recovery when then they start feeling ill again. And that is when things have kind of changed and the bacterial infection has settled in. With sinusitis, because it is more up into the closer to the brain, closer to internal structures, that you can have complications where that infection spreads to places like the meninges. So meningitis might be a complication. Also cellulitis or abscesses. So just as a reminder, cellulitis is infection into the soft tissue. And often you'll see that there is erythema of the tissue, and it may be indurated, probably a little tender as well. An abscess is an infectious process that's typically underneath the skin. So it may not necessarily be in the sinus cavity itself, but in other parts. So like peritonsillar abscess can result from an origin of sinusitis. Pharyngitis is a condition that can have multiple causes that are not only infectious, but others just in terms of irritants that get onto the pharyngeal mucous membranes. The infectious processes, again, are going to be both viral and bacterial. And the main bacterial one that we are concerned about is group A beta hemolytic streptococcus. And the reason for that is because group A beta hemolytic strep can cause either rheumatic fever, which is the strep infection gets into the heart and can cause valvular problems, or it can go to the kidneys and cause acute glomerular nephritis, and so you can have issues with kidney function after that. So when somebody is test positive for strep throat, the treatment is usually a penicillin, and the primary purpose is to eradicate the bacteria so that it can't go on to infiltrate either the heart or the kidneys. Now that said, if you've ever had strep throat, you know how bad you feel, and that once you start taking the antibiotics, usually within 24 to 48 hours, you are starting to feel better. Two other infections in the upper airway can be the tonsillitis, so inflammation of the tonsils. For adults, this is less of an issue. Tonsils are part of the lymphatic system, and when you are young, a child, they tend to be much larger, but then as you get older, they sort of reduce in size. But some people continue to have problems with them and can have a recurrent group A beta hemolytic strep infections, and so there may be an indication to have the tonsils removed. Complication of strep tonsillitis is peritonsillar abscess, so that in this case there's the abscess in the peritonsillar area. You can see where, if you were to examine the person, their uvula will be deviated, and in addition to that, the sore throat is so exquisitely painful that oftentimes these individuals will drool rather than swallow, and they will appear ill, toxic like. They will typically, this is an emergent situation because it will create stridor, so the airway is breaking up or closing off, and they need to be oftentimes admitted, perhaps even intubated, so tube to go down to keep their airway open, and oftentimes they'll have their tonsils removed right then and there. Moving on to pneumonia, so inflammation that is going to happen within the lungs, and for whatever reason there's a pathogen that is introduced into the airway and begins this inflammatory process. With that inflammation, there's also usually a fluid that will develop, and I'll talk about that in more detail in just a minute. But the other thing to know with pneumonia is that they're really considered two forms, especially from, say, the inpatient hospital perspective, that there are pneumonias that are community acquired, so the person becomes ill outside of the hospital, or healthcare acquired, so that within 48 or after 48 hours of hospitalization, the person develops pneumonia. So the pathophysiology. Everything starts with inflammation, and it spreads from the interstitial spaces into the alveoli and the bronchioles as well. The infectious organisms, or whatever the inhaled irritants are there, and they just really trigger off this whole inflammatory process. So like any inflammatory process, what will start happening is, as those pathogens start to multiply within the alveoli, the body's going to respond, and the white blood cells start to migrate to that area. That as there's all this inflammation and migration, you can have some local capillary leakage and edema and exudate right there in the tissue. So that's part of what's creating that fluid buildup. Hold on, let me go back. I skipped a slide. Yeah. So from there, what happens is at the alveoli, because of the fluid that's collected, and also that the alveolar walls are thickening as more things are coming in there, you have a reduced gas exchange, and that person will have hypoxia. Another thing that can happen is that the capillaries will have some of the infection in there, and as they leak, that can spread the infection. If it gets into the bloodstream, it can then spread and you have a patient with sepsis, or it can move into the pleural cavity, and in that case, empyema. The whole process of the fluid filling into the alveoli, the loss of compliance with the fibrin and edema, with the inflammation, all kind of come together, and that the alveoli also start to collapse or create atelectasis. The purpose of this slide is to really just show you the two types of pneumonia that can be identified on X-ray. So this is more so that whenever you are looking at an x-ray reading, that you're able to understand what the radiologist is saying. So at times there can be a lobar pneumonia, so that in one particular lobe of the lung, it's where all the consolidation and the infection is. On the other hand, you can have bronchopneumonia, and in this case, there's little scattered areas of consolidation. So in just little different parts. The difference between these clinically are not really so significant. Like I said, it's more about you having a better understanding of the terminology and what that might mean in the context of when you're reading a radiology report. So what are the things that cause pneumonia? All the infectious processes, and pretty much any variety is going to pick up. So bacterial and viral mycoplasmas, there at the end, the helminths, those are worms. So you got everything that could possibly get into the lungs and cause an infectious process. Because pneumonia is primarily an inflammatory process, there's also non-infectious things that can cause it. So the inhalation of toxic gases or fumes, somebody that has smoke inhalation, all those type of things can also create that inflammatory response. And perhaps because of the cascade of things that happen, create an environment that is going to be fruitful for bacteria to settle in and to overgrow. So you might have a secondary bacterial infection that's on top of maybe a non-infectious cause or that started it all up. As far as risk factors, looking at either the community-acquired pneumonia or the healthcare-acquired pneumonia. In the community, sort of the frequent flyers, so the older person, people that have chronic illness. If you use tobacco, you're usually on risk factors. Secondary smoke, alcohol abuse, individuals who have not gotten the pneumococcal vaccine, so they're more vulnerable. The healthcare-acquired pneumonias, some of them are similar, so the older adult, but also any individual that has a chronic lung disease, if they have gram-negative colonization, or if they have ALC, altered level of consciousness. Any recent aspirations would also put them at risk, and if there are any foreign tubes that we've put in them as a way to manage some other component, so endotracheal tubes, so those tubes that are used to help to mechanically ventilate a person. Patient that has a tracheostomy will also be at higher risk for healthcare acquired pneumonia. And then any patient that has a nasogastric tube, so that tube that's going from the narrae down the esophagus and into the stomach, that just the presence of that tube sets somebody up to have a greater risk for pneumonia. If the person has a poor nutritional status, that makes them higher risk. And then if there is a increase in gastric pH, meaning that the pH has become more alkaline, so the person may be receiving medications like H2 blockers or maybe proton pump inhibitors, anything, either one of those that decrease the pH. And then finally, mechanical ventilation is a huge risk factor. The pathogens that cause community-acquired pneumonias are listed here. These are kind of the frequent flyers for really all of the both upper and lower airway infections. So if you were to look, what are the things that are more likely to cause sinusitis, bacterial-wise, it's the same for pathogens. And similarly, the viral infections are usually these that are listed here that start out as a cold and maybe go on to become something more significant. The symptoms for pneumonia, so these are the things that the patient either reports to you, but they may have chest pain. They may have some generalized feelings of sort of myalgias, so a little muscle achiness. They could have a headache. Probably they have cough and a fever. They may have shortness of breath. When they cough, it may be productive, and then on top of that, they may have hemoptysis or bloody sputum. The weakness, fatigue, confusion, poor appetite, and sleep disturbance, often these symptoms are what you see in the elderly patient, so that while they may not have the immune system that's going to really be able to generate a good inflammatory response and create a high fever, they would still have those changes in their respiratory status and probably some of these other, pardon me so much, some of these other symptoms where they would be confused or extra weak. The signs that you would see for pneumonia, starting out respiratory type symptoms, so that they will be tachypnic. They'll be short of breath. You'll see that they're using accessory muscles. When they cough and have a productive cough, what you may be able to see is a purulent discharge, or maybe blood tinged, or even a rust color. Probably in trying to take in breaths, you see that they have increased work in their breathing, and so they might be using accessory muscles. Individuals who have pneumonia, in terms of the breath sounds that they hear, are going to be any variety of things. It's no one thing. So it may be rales, so those sounds that are made on inspiration, so at the little collapsed alveoli, all that atelectasis, and as a person takes a deep inhalation, they start opening up. So pop, 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 pop. Bronchi is a sound that usually is coming from the inflammation of the bronchi, and it is typically heard on expiration, and it sort of has a sonorous or sort of snoring type sound to it, so like that. Wheezing is going to be high pitched and sort of musical, so and wheezing is typically heard on expiration. So if you have a patient who is having difficulty with breathing and you have them do a forced expiration, oftentimes you can hear that wheeze with that. The other thing that happens with pneumonia, because of the consolidation, is you can sometimes have changes in the breath sounds as you listen from side to side. So you always are going from side to side to use the patient's lungs as their own control. So you expect the lungs to sound equal on both sides. But if there is consolidation, the breath sounds will be decreased. So on the side without the pneumonia, you might hear a nice whereas when you listen to the other side, it might be more, so just much softened from where it would have been otherwise. And then finally, these individuals, because they may be having some hypoxia, the gas exchange isn't what it should be, that they would have low O2 saturations. The diagnostic tests for pneumonia include chest x-ray, so that'll be help to localize where that pneumonia is. Other things, the sputum exam. This is something that typically is done more in the hospital than, say, when people are being examined for pneumonias out in the community. Because it's hard to get a good sample. There's a lot of contaminant if you just have somebody sort of cough up and spit out their sputum. It's often better if you're able to sort of suction out some of what they're trying to have. But sometimes they will go ahead and do that, and that they'll look at a gram stain culture and sensitivity. Other tests that are done for pneumonia include the ABG, so arterial blood gas. So this is the gold standard of really looking at how well the patient is taking in oxygen, whether their carbon dioxide levels are okay. Also gives you an opportunity to look at their base excess or their whether or not they're acidotic or alkalotic. CBC, so a complete blood count. This can tell whether or not there's been a shift and if the patient is developing lots and lots of little immature white blood cells. So sort of the extent of the infection would also tell you about their hemoglobin. So how well are they able to carry the oxygen right now, given everything that's happened. Their basic metabolic profile. Oftentimes with pneumonia there is dehydration that may be happening, so being able to look at the electrolytes, also looking at kidney function would be important, as it's highly likely that there will be antibiotics that are started that may well be excreted in the kidneys, and so need to make sure that baseline those things are working well. And then because you know that with a pneumonia that can spread and become systemic and cause a sepsis, oftentimes a blood culture would be indicated so that you can evaluate that up front. This extra, that's a mistake. I meant to take it out before I started. Oops. All right, so medical management of a pneumonia, antibiotic therapy. And so depending on whether the patient has community-acquired or hospital or healthcare acquired pneumonia, a decision will be made about what antibiotic to treat them with. Individuals who have pneumonia may also be given bronchodilators, so that inflammation can cause bronchospasms, so the bronchodilator may be helpful. Sometimes IV steroids are also going to be used. So this whole process of the pneumonia starts with inflammation. So by giving intravenous steroids, that can help to decrease that inflammatory response, and so that along with the antibiotics are going to help to better stabilize the patient's respiratory status as you sort of quiet that inflammation and start treating the infection itself. Supportive therapy that would also be included, so hydration, since this is a patient that very well may be dehydrated. The supplemental oxygen, so most of these patients will need to have oxygen. If you have a pneumonia, oftentimes you can be treated and followed well in the community. But if somebody has a new oxygen requirement, then that certainly supports them being hospitalized. So as the nurse, it's going to be my job to make sure I'm following what the patient's on, that they're receiving the correct amount of oxygen, and that I'm assessing that delivery system, that it's not creating more problems like breaking down tissue, and I'm making sure that it's positioned in a ways that won't be more likely to create that tissue breakdown. Antipyretics could be very important. So for the patient that is experiencing fever, that is really a difficult thing to sort of experience and makes you feel worse. So alleviating that symptom can be very beneficial just for the overall comfort of the patient. And then finally, ventilatory support. So the patient that's not able to maintain their own airway, not able to breathe, would require mechanical ventilation or perhaps CPAP. Nursing diagnosis here. I think these are pretty straightforward. Notice that there's both problems for gas exchange but also airway clearance, given the mucus production that could possibly block the airway itself. For the nurse in managing these symptoms, things to target, so the hypoxemia. So the oxygen therapy, will be managing that and making sure that the patient's having delivered the correct amount of oxygen. Using the incentive spirometers, so those little devices where the patient takes a long, slow inhalation and is trying to hold it, so this helps them to maximally expand the lungs, and that's going to help to open up those alveoli. Preventing airway obstruction, so sort of along with the incentive spirometer, is to add the coughing. So that nice, long, slow inhalation, and then focusing on coughing and clearing the airway. Also, we'll encourage fluids, provided the patient isn't on a fluid restriction, but that we would want them to take adequate fluids, hopefully by mouth, but they may also need to have adequate fluids delivered to them intravenously if they are unable to take them by mouth. And then finally, to try to prevent sepsis. So making sure that we are delivering the antibiotic doses in a timely manner, and that we're doing all the other things to prevent complications that go along with immobility that might lead to more stasis. So stasis that might be urinary, or that which would happen in the lungs. So just those two things. All right, influenza is the next topic. Seasonal influenza, so highly contagious viral infection. This is something where a person is contagious 24 hours before they even have any kind of symptoms, and then 5 to 7 days after that. So that window of time when the person isn't even contagious, I think that's when a lot of us end up getting infected. But it is a condition that has a very acute onset, and if you're interested in kind of getting a better snapshot of all that's happening in this year's flu season, I have this web address here that you can visit and find out more. Also know that the patient that has a seasonal influenza is going to need to have droplet precautions, as they will be infectious. Influenza complications. So most of these are going to happen in either the upper airway or the lower airway, but it's still airway related. Younger individuals, children, are more likely to have ear infections, but sinusitis, acute bronchitis, pneumonia, are all possibilities for the adult population. The other thing that can happen is if an individual has a chronic illness, the influenza oftentimes will exacerbate it. So the patient that has asthma, influenza is going to create inflammation, and that may get the whole cascade of activities as far as asthma reactivity. The patient with chronic obstructive pulmonary disease, or COPD, worsening of sort of the inflammation, and so their symptoms may become worse as well. Same for the patient with chronic congestive heart failure. And then for the patient with diabetes, anytime we become ill, that's going to mobilize our glucose stores, and so that's going to be more in the body system. So for diabetics who are less able to handle those increased glucose stores, once they get into the bloodstream, they're much more likely to have really out of control blood sugars, and where they're going to have to watch them much more closely. The signs and symptoms of influenza. So the symptoms are going to be more systematic, so they may have muscle aches and just generalized lack of energy. Then some of the symptoms are going to be more upper airway type of things, so cough, sore throat, runny nose. They may also have a headache and fever. So all those things coming together. It's often those body aches and the rapid onset of symptoms that help to differentiate it from a cold. Whereas colds kind of slowly progress and you don't feel so good. With influenza, at one point you're feeling good, and then maybe you wake up after being asleep and you have a fever and the body aches and everything. As far as the signs, most individuals who have influenza will have just an ill appearance to them, and oftentimes when you check their temperature, it'll be elevated. So just in differentiating these two, the symptom of fever, they're telling you I've had a fever, and the sign, you're checking their temperature and finding they have an elevated temperature. The other thing that I wanted to mention around the flu is just a reminder that individuals that have it will be acutely ill, or the more significant symptoms are usually within that first 5 to 7 days. But even for a week afterwards, they may have generalized fatigue that just kind of lingers before they really get to the point where they feel 100%. Populations at risk for the flu: the elderly, over 50. I guess that's not as elderly as it used to be for me, but anywho, if the individual has any kind of chronic illnesses, or if they're immunocompromised, if they live with somebody at risk, or if they are in an institutional setting like a long-term care facility, and then if they're healthcare providers like ourselves, who will be in contact with people who may be in that little window of being asymptomatic or just exposed to whom when they are sick, so that we would have a protection so that we don't get ill. For the vaccines, just a reminder that the main contraindication for the vaccine is if a person has an egg allergy, or if they've had a previous reaction to the vaccine. For some people, I mean, if they're really concerned about the risk associated with the individual getting the flu, if they had an egg allergy where the response wasn't as acute or serious as some of the others, they may determine that the benefit of getting the vaccine outweighs the risk of the egg allergy. So that definitely would be a decision typically made by a physician, but just among the scope of possibilities. The vaccine comes in both the form of an injection, and it also can have a nasal spray. The injection is inactivated, and while the nasal spray has been weakened some, it has more live vaccine in it, so that while it might not get the person who's having it given to them sick, if there's somebody who's immunocompromised, or if a person is immunocompromised, that wouldn't be the delivery system that would be best. Once a person has the vaccine, they should stay around for 30 minutes to make sure that they don't have a reaction. And once the vaccine has been given, the antibodies are going to develop. It usually takes about 2 weeks. So hopefully within that window of time, a person's not going to be exposed to the flu and potentially get it. Although most of the time the vaccine only covers so many types of strains of the flu, so you could still get the flu even though you had the flu shot. It typically is going to make the response less problematic than it might have been, but you still might get sick. All right, so moving on to the last topic, which is pulmonary tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis, and it's going to be transmitted by way of the air, so aerosolization. So when I'm talking or laughing or coughing, I'm spewing out those little bacteria. The tuberculosis kind of makes its way into the body at different stages, so that there's some initial infection with a sort of the primary disease that sort of happens originally, and then there's the latent disease where the person's been exposed but they are not infectious at that point, or contagious. They're not going to spread it, but they can move on to have active disease where those dormant Mycobacterium that had just been sitting there are released and are able to duplicate and go on to cause a problem. So let me talk about each of these. So with the initial infection, somehow there's an inhalation of the little droplet particles that have the TB, and the bacillus are able to get into the airways, so the bronchi or the alveoli or both, and they start to multiply. And there's sort of a response to that by the body, so that it's trying to go and attack this foreign substance. So that with that, the body will create a cell-mediated immunity. So within somewhere around 2 to 10 weeks of exposure. And with that, the inflammation starts to be surrounded by collagen and fibroblasts and lymphocytes to try to wall off that bit of the bacilli. So after that initial infection, the patient will go into latency. And what that means is, as that walling off happens, there's a caseation necrosis that has been produced, and while it's containing the bacilli, there's still some viable tubercle bacilli that are in it. And what can possibly happen is those necrotic areas can calcify, so not really have anything happen to them, or they can liquefy. And it's important to know that with those caseation necrosis, that if you were to do a chest x-ray, you really can't appreciate them at that point in time. So you would still have a normal chest x-ray. Now, what happens with active disease is there where there had been those necrotic areas, if they go on to liquefy, that liquefied material can just sort of empty itself into the bronchus. And so it creates this cavity where now the bacilli can have space to really start growing and replicating. So as they grow and replicate, now they can get into the lymphatic system and start to move in across the lungs. They can also move to other areas that aren't part of the pulmonary system. So, for example, people can develop TB meningitis. So what do you see clinically if you're looking at the different TB-related conditions? So if you're looking at latent disease, those individuals are going to have a positive skin test. They'll have a negative chest x-ray. They're not going to be sick, and they aren't going to be contagious. But they are typically going to be treated so that it prevents them from developing full-blown disease. TB active disease, now they will have a positive skin test, but because the disease has been activated and been able to multiply, it's going to have more of an impact on the lungs, so that you'll see an abnormal chest x-ray. If you were to take a sputum culture, it would be positive. And usually these people at this point are going to be symptomatic. So they don't feel well. They're usually going to lose weight, and they're going to be contagious. Sorry about that misspelling there. And here the treatment will be given with the purpose of trying to treat the disease. I like this image because it does help to kind of show the two pathways that might happen with that initial infection. So where it gets walled off and person goes into latent disease, about 90 to 95% of infected individuals will go that course. But there's that other 5 to 10% of individuals that are going to go on to have active disease. So that may happen immediately, or it could happen where the latent disease had been walled off and then there's some sort of secondary infection. So a reaction to the TB after the person maybe has become HIV infected, or there's some sort of immunosuppression. Risk factors for people as far as whether or not they might contract TB. So if they live with somebody who's infected, that puts them on up there. If their immune response is compromised, if they lived in any kind of crowded setting, so often places like jails are particularly high risk. older or homeless individuals, addictions can be problematic, and then lower socioeconomic status, recent immigrants, or foreign travel. The individual who has active TB will have probably more symptoms than they do signs, so that they will tell you that they have become more and more fatigued, that they've had unintentional weight loss, maybe that they don't feel like eating, maybe they have night sweats or low-grade fever, chest tightness, cough. And the signs may or may not be there. You may listen to their lungs and really not appreciate anything. So oftentimes having to move on to diagnostic tests to really pull together what's happening with the patient. So the order of these tests are typically going to be the TB test or the Manto, and depending, some places have already moved into just doing the TB blood tests, and there's 2 of them that are available. Once the initial testing comes back positive, then that will bring further testing that would include definitely a chest x-ray and possibly a sputum culture as well. Treatment for TB usually will involve combination drug therapy, and there have been some drugs that have been used for TB for as long as it's been there, so have done a good job in terms of trying to prevent resistance, but continue with the combination drug therapy to avoid the multi-drug resistance to TB. Medication adherence is most important, and the duration varies depending on what's going on with the patient. Sometimes there are significant problems or barriers to adherence such that a healthcare provider, typically a community care nurse, will make home visits, and they may have to do directly observed therapy so that they watch the individual take the pill and swallow it down.